presenting a case today that I've been following along with Dr. Nguyen at the Glen Burnie Clinic. So this is a patient that we saw at the Glen Burnie Clinic. It was a 31-year-old male. He was referred by his PCP for right lower extremity varicose veins. He had bilateral lower extremity edema, heaviness and fatigue greater in his right leg than his left. He reported that his varicosities on the right leg have been present since the age of 15, and his symptoms began in 2014 after his duties in the U.S. Army after he began flight jumping. His symptoms are moderate, occur throughout the day, and more recently they've been beginning to interfere with his job duties in the Army, typically alleviated by elevation, compression, and aggravated by prolonged sitting and standing. He has been using 20 to 30 compression stockings regularly for the past 6 years as prescribed by his primary care physician, and he denied any pelvic symptoms on initial consultation. So his review of systems, mostly negative. He did have a past medical history of a DVT in his left lower extremity, reported below the knee in February of 2020, and this was thought to be provoked by a 16-hour flight. He didn't report any history of thrombophilia during his initial consultation. He didn't have any significant surgical history, doesn't smoke, occasional alcohol use. Family history is positive for hypertension, MI, but his father and his mother had diabetes and history of having a stroke. He wasn't currently on any medications. He wasn't allergic to any medications. Initial physical exam was mostly unremarkable. No ulcers or obvious rashes on his lower extremities. BMI is 29, pretty big guy, 6'2", 230 pounds, but wasn't really obese or anything, kind of more muscular built, a little bit overweight. And so on his initial physical exam, he had the varicosities that he mentioned on his right lower extremity. You can see in the picture on the right, going down below the calf, and he can't really see too well. This is the best picture I could get, but the varicosities did run up his thigh, pretty much to his mid thigh, and on his left leg, no real obvious varicosities. It's kind of hard to appreciate, but he did have edema bilaterally, but definitely worse on the right leg. And so his initial scan showed deep system reflux bilaterally and bilateral GSV insufficiency, as well as small saphenous vein insufficiency as well bilaterally, thigh extenders present, and a few tributaries on the right side, but none on the left. And so our initial plan for this gentleman was to do radiofrequency ablation of the right GSV and a phlebectomy 10 to 20 as the first procedure, followed by the left GSV. Both of those are proxy to distal calf. And then to treat his SSVs on the right mid-calf to distal calf with a phlebectomy of 1 to 9. And then on his left SSV, he did have some reflux going into that thigh extender. So the plan was to do mid-calf to distal thigh and then try to get the thigh extender. And then, of course, follow up with the tributaries on the right leg with some USG. And he did have all that deep system reflux. He didn't mention any pelvic symptoms, but just with the amount of reflux that he was having and varicosity that was kind of running up his thigh. And he did say that based on the picture that I showed, but he did say that it does it intermittently. He can see that the varicosities bulge out pretty good on the right side going up to his thigh. So after getting his lower extremities treated, we definitely wanted to get him over to CVM for evaluation to make sure nothing higher up was going on. And so on the initial procedure, which was done last month. The RFA of the right GSV and the phlebectomy, the access was 6 centimeters above the knee. Below the knee, the vessel was pretty tortuous, and that didn't seem to be a really good access site. So it's 6 centimeters above the knee. The catheter was placed 3.08 centimeters from the SFJ. 3 cycles and 21 centimeters of the GSV ablated, and then did a 4-stab incision phlebectomy at his right mid-calf, kind of more medially. And the entire procedure time was roughly about 46 minutes. And so he tolerated that procedure pretty well. Overall, there was nothing too remarkable about that procedure, but he comes for his post-ablation scan on the 7th, and the GSV is occluded, but we do identify a E-hit level 1 on the scan. So there is a few pictures here that I put on here. They're not, some of these aren't too clear, but this is the E-hit that we saw based on the scan that we did on the 7th. And then, so we spoke with him. He wasn't really having any pain, any symptoms or anything like that, just a little bruising from the phlebectomy, but otherwise he was feeling all right. And we decided to go and treat the left GSV. And on the left GSV, we accessed 6 centimeters above the medial malleolus, and the catheter was placed 3.88 centimeters from the junction. And on this one, we did 14 cycles, and 49 centimeters of the GSV was ablated, double cycles at the proxdistal mid-thigh and the prox calf. And the procedure time was 40 minutes. So he comes back for his post-ablation scan for his left lower extremity. GSV seemed to be occluded. There's no evidence of DVT or E-hit or anything on the left side. And so we continue on with the treatment as we intended. And we start treating the right SSV with RF and phlebectomy. And on this procedure, access was 8 centimeters above the medial malleolus. RF catheter placed in the mid-calf, 1 cycle and 3 centimeters ablated. 2-stab incision phlebectomy at the right mid-calf. And this procedure time was 30 minutes. So far, as we're going through these first 3 procedures, nothing too out of the ordinary except for the E-hit that we saw. But in terms of symptoms in between, besides bruising and just a little bit of soreness, nothing overall that was too out of the ordinary in terms of the symptoms. So now on the 14th, after his treatment with his SSV, he comes back for the follow-up scan. And then now he's reporting pain, swelling along his right lower extremity, primarily by his proximal mid-calf, a little bit going up to his distal thigh. The pain's pretty moderate. He's feeling the soreness at rest, and he's definitely having some pain during ambulation. And the ultrasound that day shows occlusion at the right femoral vein, distal thigh, the popliteal vein, gastrocs, mid-calf, distal calf. And, we see the E-hit level 1 from the scan that we saw previously the week before. And so during his initial consultation, he was asked about, family history of thrombophilia, if he had any history of thrombophilia himself. He did have that DVT back in 2020. It was thought to be provoked by that 16-hour flight. So Dr. Nguyen and I spoke with him, and just to kind of make sure that there wasn't anything else that we're missing. And he does mention that a possible history of factor V latent at this visit. I did try to get in contact with his PCP. So he had a PCP with the Army, and then he had like a civilian PCP. I wasn't able to get in touch with the primary care physician that he sees in the Army, but I was able to get in touch with the other PCP that he has, and she wasn't aware of any history of factor V. She just known about the clot that occurred in 2020. But regardless, we started him on Xarelto. And so I'm just going to go through a few pictures here of the ultrasound that we saw that day. So this is the week before we had seen the E-hit, and this is the follow-up. We see P-thrum at the right GSV junction. And then there was occlusion of the femoral vein, distal thigh. The popliteal vein. And the gastrocs mid-calf, and this is the mid-calf, and this is the distal calf right here. So the patient was started on Xarelto on the 14th. And so he comes back on the 21st, and the ultrasound that day doesn't show anything in the right femoral vein or the popliteal vein. And there's P-thrum at the gastrocs and mid-calf, distal calf. His pain, bruising, edema are improving. We advise him to continue on the Xarelto at this point and bring him back for another follow-up scan. And this is just the P-thrum of the gastrocs that we see on the 21st. And so he comes back on the 4th on this month. He's still reporting some pain at the right calf. He has been taking his Xarelto. Ultrasound on the 4th of this month shows occlusion of the right gastroc, prox calf, but not the mid calf. So things seem to be resolving. There's nothing in the femoral, the popliteal, and we're holding off on procedures at this point, of course. And then he's still advised to continue on the Xarelto. And then let me go back. So let me amend what I just said. So he had he was reporting pain at the right calf, and previously it seemed to be improving, but today actually on the 4th, the ultrasound shows occlusion of the right gastroc prox calf, but not the mid calf. But on the scan, as previously it said that we were seeing kind of P-thrum and it was resolving, but on the 4th, we actually see it's read as a acute DVT of the gastroc on the prox calf. So that was kind of a little out of the ordinary. We'll go back and compare the images of from before and the images that we see right here. So he's continued on the Xarelto. On the 18th, there's no acute DVT in that gastroc that was initially P-thrum and then read as acute on the 4th, now is read as P-thrum again. And we're going to continue the patient on the Xarelto for a total duration of 3 months. And I followed up with him. His pain, bruising, it all seems to be resolving. He does want to eventually continue on with the rest of his treatments once we get past the duration of his Xarelto. So a few things about this case. He had the clot back in 2020. I tried to dig up more information in terms of his history. I couldn't really get in touch with his Army PCP. And he has part of his job in the U.S. military was to go on a lot of long flights, a lot of travel. So that itself, on top of this possible history of factor five, were the risk factors for him throwing the initial clot. And then, of course, we're doing these ablations. So I just wanted to kind of touch on factor five Leiden. I know Dr. Harris touched on it last week with his thrombophilia lecture, but factor five is encoded by the F5 gene. Procoagulant clotting factor amplifies production of thrombin. This is autosomal dominant, and 99% of patients are heterozygous for the variant. The 1% homozygous are definitely a lot more high risk. Of the heterozygous variants, 5 to 10% of these patients will develop venous thromboembolism in their lifetime. And there's a chart of kind of more common thrombophilia is protein C, S, antithrombin deficiency, and at the bottom, G20210A. The bottom two, it's not uncommon for factor five Leiden patients to also have the G2 thrombophilia as well. That also kind of, when I was reading up on it in some of the hematology journals, they were mentioning that a lot of these patients who have these combined are usually the 5 to 10% that end up having the venous thromboembolism, but just factor five Leiden itself gives you a 4 to 5 fold increased risk. And of course, the risk of venous thromboembolism can further be increased by older age, homozygosity for the factor five, co-inheritance of another thrombophilia, acquired factors such as pregnancy or estrogen-containing contraceptives. The most common clots are DVT and PE, and then followed by like superficial vein thrombosis, cerebral venous thrombosis, portal vein thrombosis. So anticoagulation is generally treated the same with people with the heterozygote mutation, along with the general patient population that doesn't have factor five. It's treating these patients more aggressively. There isn't much evidence to back that up, especially if the patient's a heterozygote. Some exceptions for like prophylactic anticoagulation is patients going under high-risk surgery. We always have to take into consideration any OB patients, especially history of miscarriages and during their pregnancy. And in terms of testing, usually patients with factor five, they don't really, if there's no history of VTE or anything like that, they don't really recommend routine testing. And of course, if you do need to test and they're on anticoagulation, wait until they're done with their anticoagulation, Xarelto or warfarin. So I kind of wanted to go back. So on the 4th, we had, this is read as like a acute gastroc clot. And on the 21st, we had P-thrum over here. So I just wanted to get some thoughts from anybody, or if anybody had any questions or.
Yeah, so Sagar, I have numerous questions. So can we go right back to the very first ultrasound?
Yes.
Yeah.
The report?
Yeah, right here.
Yeah.
So how often do you see patients who have both GSV and SSV reflux in the same limb? Is that common?
No.
So how often do you see that?
I'm not sure the exact
So it's about 9% of the
9%.
time. So 91% of the time reflux is either in the GSV or the SSV, but having them combined is very uncommon. So the question always is, there's data to show that if you treat the GSV, sometimes the SSV reflux goes away because the posterior accessory saphenous vein oftentimes connects with the small saphenous vein. So the question always is the reflux coming secondary from the GSV? And oftentimes you see this pattern here where the junction and the prox calf is normal. And that's because that posterior accessory vein connects to the SSV right there in the mid portion of the vein.
Yeah.
So there is a small percentage of those patients that if you treat the GSV reflux, the SSV reflux goes away. So my second question is, when you saw this ultrasound report, did the text combine tell you if there was a large thigh perforator that connected the SSV to the femoral vein? Do you remember?
No, not initially, no.
So did you go back after the patient had a DVT to go look to see?
After the patient had DVT, I went back and looked at the report because there was so much going on with the report, but I didn't
Yeah, so one of the
look
things,
specifically at the images. Yeah.
so one of the things I want you to think about is that, you know, when I look at Teresa's data,
Mhm.
we do have an incidence of a DVT with thermal ablations in remote sites other than this junction, like this patient, like you had here.
Yeah.
And when I've gone back and I've looked at a lot of my own patients myself where this happened to, there was a very large thigh perforator that a clot developed in the thigh perforator and it just tracked down into the femoral vein right where you see these clots.
Yeah.
So whenever I've gotten to the point where I've told the techs if they see large thigh perforators on the duplex scan to let me know about it. Because what I'll try to do is when I do the thermal ablation, I'll try to ablate above it and a little bit below it, but not right at the thigh perforator. Now, most of the data shows that even if you ablate that thigh perforator, it usually stops right at the femoral vein junction because of the flow dynamics. But the patients that I've had femoral and popliteal DVTs, remote DVTs, usually there's some abnormal connection that I didn't fully appreciate at the first time.
Yeah.
So when they present with a DVT like this, I would encourage you to tell your techs to go and look to see, is there that thigh perforator there? And my second question is the initial clot, did this happen after the SSV ablation or before it?
After the SSV ablation.
So the SSV ablation occurred on the same side as the initial GSV ablation, correct?
Yes.
So was there any evidence of an EHIT 3 or 4 after the SSV ablation?
Yes. So the right GSV was treated, left GSV was treated, and the right SSV was treated. We saw the EHIT after the EHIT 1 after the right GSV.
No, I'm not talking about that. I'm saying, was there a clot at the saphenopopliteal junction after you did your ablation of the SSV?
Yeah, so EHIT 4.
There was. So are you attributing the clot at the femoral and popliteal vein to the RF that was done?
Yeah, so after the SSV, the right SSV was treated, we saw the femoral distal thigh and the popliteal vein. So yeah, I was attributing the clot to
But yet the EHIT 1 never changed, right? It was stable.
stable, yes.
So what are you going to do now with all these tribs? Now that he's had these DVTs and you have him on Xarelto? I'm sorry.
Well,
I'm sorry. Let me rephrase that. What are you going to do with the remaining below knee disease because you've already treated some of the tribs?
Right. So I would, since we treated the GSVs, I would see if just treating that and the decrease in pressure there, see if these tribs kind of decrease in size if we don't need to treat him, especially with his history with him clotting like this. I would kind of wait and do a rescan to see after his anticoagulation.
So,
instead of jumping straight
based
to the
on
treatment.
based on your experience of one, what would you do differently if you see another patient that comes into the office and tells you that they may have either a remote history or a confirmed history of a hypercoagulable disorder? Would you anticoagulate them before you did the ablation, or would you say, well, what the hell?
I would, with factor V, or any thrombophilia. And I was kind of discussing this with Dr. Stewart. I don't think there's strong evidence just to go ahead and anticoagulate. He had the DVT in the past, and a questionable history of thrombophilia. I would, me personally, I would probably go ahead and prophylax with xareltone.
So I would, and I'm going to give you like a lawyer's dodge on this one. So beware the N of one, right? So there's always this guilt that you feel when you get a complication and, oh my God, did I do just something wrong? And then you reflexly just kind of say, well, next time I'm going to anticoagulate all of them. I would encourage you to go do a literature search on this and see. There is a lot of data, especially from the University of Michigan, about anticoagulating patients who are getting ablations. So what Tom Wakefield's group did about 20 years ago, 15 years ago, when RFs were started coming out, they anticoagulated like about 5,000 of these patients, or I don't remember the exact number, to see if it would minimize their DVT rates. And the only thing that happened was they increased their bleeding complication rates without minimizing DVTs. Now, that was not in hypercoagulable patients, that was in all comers. So there may be a certain instance in which you might want to anticoagulate somebody before you do an ablation. I don't know if this person would have been a good candidate for it. I'm just throwing it out there for you to have some intellectual curiosity and maybe go and do a literature search to see if anybody has like a series of 4 or 5 patients in which they've done this in, because I don't know the answer. But I think this, you bring up a really, really good point here in this case. And I think it's something that, well, I personally would like to know, and I would be curious if the rest of the group wants to know. So does anybody else have any questions for Marlon? Go ahead.
Thanks, Peter. Great case, by the way. Looking at this image, he had a single history of DVT 16 years ago or something, correct?
That was in 2020.
Okay, so he had a DVT in 2020, but it was only in one leg.
Yes.
So he's got bilateral deep vein reflux. He may or may not have a family history. I think that it is something that we do have a thrombotic risk with everything we do. And the Michigan group, if they did it to everybody, in other words, prophylaxing, that may not be the right approach. But if you take somebody who has had a prior event, and I've seen a lot of these patients, and I don't believe that 5 days of a prophylactic anticoagulant is a problem, especially if the patient asks, am I going to get a blood clot from this procedure? You can't predict it. So I think having an option where if you have that discussion with the patient would be a valuable discussion. We can't keep from having all patients not having a thrombotic event. These are going to happen. But he was at higher risk. And if that conversation were to happen, offering them a prophylactic dose for 5 days is what I've been doing. It's very well tolerated, and it seems to have mitigated a lot of the patient's concerns. Maybe I'm treating myself, but I don't think that's a long-term course or anything. The other comment, this guy had a provoked clot. It doesn't mean he didn't have factor V Leiden and an underlying thrombophilia that put him at that risk. So just because somebody has a provoked clot, we can't just assume that it was because of the provoking event. If 5% or more of people have thrombophilia, then that's something that we have to consider even with that history. Just a thought.
Yeah. Eddie?
Quick question. For that study in Michigan, were they using warfarin or the NOACs?
No, at the time they were using Lovenox.
Okay. So And then lastly, to Dr. Patel, did you guys ever then try to finalize this question about the factor V Latin? Has he been gone for any thrombophilius studies to?
No, I tried to reach out with his primary care docs to see if there was any studies done. Didn't get an answer there, but no, he's still on the Xarelto. So I think after we get him off the Xarelto, I think, if this is still questionable and we don't pull up any records, we can get him tested.
I think it just to be aware, I think at this point you have identified a possible a thrombophilia issue, and I think it perhaps merits that you guys identify that to, because now you have documentation. It shouldn't be just from a medical legal perspective rather than.
And
So
Sagar, remember, the hypercoagulable disorders, the prothrombin 2 gene mutation, MTHFR, and factor V, those are PCR tests. So you can do those tests even while they're anticoagulated. The other factors you can't do while they're on an anticoagulant. But for the one that you're concerned about, since he gave you a remote history, you can just go ahead and order that test. You don't have to wait for his primary.
Yeah, and also perhaps getting that pelvic evaluation done, even though he's in anticoagulation, make sure that there's nothing further promoting his prothrombotic state.
Yeah.
And that's also something that can happen now.
So Sagar, what do you think now that he's had 2 documented DVTs with a possible history of an prothrombotic state? You think you should anticoagulate him for life?
No, I don't think I should anticoagulate him for life. He's had one from these 2 provoked, one potentially from the plane ride, and then the ablations that we did.
But what are you going to tell him about his career now? Should he continue jumping out of planes and taking 17, 18-hour plane rides?
No.
Yeah,
He started to, like, when I spoke with him about his career, he's not doing that as much anymore. Like he initially started flight jumping back in 2014, but he doesn't do that anymore. He kind of transitioned back to other duties in the U.S. Army.
Okay, so why did you say that you wouldn't consider anticoagulation for life? What's the current, ACCP guideline recommendations?
So I'm not completely sure, but I'll look it up.
So Marlon just said it's 2 documented unprovoked, but my recollection was that if you have 2 to 3 documented DVTs, whether they're provoked or unprovoked, it merits consideration, especially in someone who may have a history of a clotting disorder.
Yeah.
So going back to Eddie's comment, I think it's vitally important you find out if he does have a factor V Leiden deficiency, because if he does, and he's had these 2 documented DVTs, and the other thing, by the way, does having varicose veins put you at an increased risk of having a DVT regardless of your genetic predisposition?
Yeah, it would.
Yeah, it's actually the #1 risk factor. It gives you a 7 to 10 times greater risk of developing a DVT at some point in your life compared to the general population that does not have varicose veins. So, indeed, Marlon says indeed. Okay. Anybody else have any questions for Sagar?
I don't have a question. This is Zoe. I would like to see your literature search, what you come up with the anticoagulation. Sagar, if you could share it with us.
Sure. Yeah.
Thank you.
So what are you going to do about the pelvic stuff?
I would have them sent over sooner than later.
Well, does he feel better now in terms of his pain and swelling, other than the discomfort he's having from the gastroc DVT? Does he?
Yeah, he does feel better.
Does he need the pelvic ultrasound from a symptom perspective?
From a symptom perspective, no.
Yeah. So then, if he's not having any symptoms, his pain and swelling is managed with the infrainguinal stuff that you did. I don't see an overwhelming need to send him for a pelvic ultrasound, especially because if you do end up stenting him, then he is going to stay on the blood thinner for the rest of his life.
Yeah.
So you need to make sure you have a pretty hard indication for get the pelvic ultrasound and plus or minus stenting him. All right. Let me see. Let's check the chat just to make sure I didn't miss any other questions. No. All right. If nobody else has any other questions, I'm going to wish you all a great weekend. Very good case, Sagar. I enjoyed this. This was stimulating.
All right. Thanks. I appreciate
All right,
all the
guys.
information. I'll look up the literature.
Yep. You guys have a great weekend.
Thank you, Sagar.
Bye.
Bye-bye.
Thanks, everyone.